everybody. Thank you so much for joining us for our coffee conversations today. I'm Janita Holt with Forge Breast Cancer Survivor Center. We are here with Dr. Rummage to talk about breast cancer and hormone therapy. She has a wonderful presentation to give us today. So Dr. Rummage, could you tell us a little bit about yourself and the work that you do?
Sure. I am a breast cancer pharmacist and a lymphoma pharmacist. I work at the Kirklin Clinic here at UAB, and I mostly do oral anti-cancer medications. I am really passionate about patient counseling and patient education, as well as drug affordability. I'm also a preceptor here for our pharmacy residency, and so Alex is with me, Dr. Rayleigh, and he'll also be presenting. He is a current PGY1 resident.
All right, well, thank you so much, and thank you for joining us today, Alex, Dr. Riley, excuse me. So without further ado, Dr. Rummage, if you would like to, you can go ahead and give us your presentation. We're so excited. We're happy that you came to educate us.
Okay, thank you. I'm going to try to share my screen. Let's see. Okay, hopefully y'all can see that. Okay. Again, my name is Claire Rummage. Sorry, my Zoom name is Crummage on here. I should have fixed that. Didn't even realize that. But like I said, I am a pharmacist here at the Kirklin Clinic, and I am very passionate about patient education. And so today's presentation is tailored to patient education about hormone therapy. And then Alex will also be discussing further side effect management of hormone therapy. Today I have nothing to disclose, and I want to discuss hormone therapy, breast cancer treatment, and review side effects of hormone therapy, and also review side effect management. Sorry, I'm just going to move this so I can see everything. Okay, that's better. So what are hormones? Hormones are chemical messengers in the body. Today we'll be specifically talking about estrogen and progesterone, and these are hormones that are produced by the ovaries in premenopausal women and by some other tissues like fat and adrenal glands in both premenopausal and postmenopausal women. Postmenopausal women do not have working ovaries, and so that's not the main source of estrogen. So for postmenopausal women, the main source of estrogen is usually in the fat and adrenal glands. Estrogen promotes the development and maintenance of female sex characteristics and bone growth, while progesterone plays a role in the menstrual cycle. These receptors, the hormone receptors, specifically estrogen receptors, are all throughout the body on different organs. And so when we use anti-estrogen or anti-hormone therapy or therapies that change hormones, then it can affect other organs in the body. What exactly is hormone therapy? Well, hormone therapy helps stop cancer growth stimulated by hormones. It can sometimes be called endocrine therapy, but today we will not be talking about hormone replacement therapy for menopausal symptoms, and we won't be discussing birth control. But it is important to realize that hormone therapy in this setting is not birth control. I have had some patients that get confused about that, and I can understand the confusion because they're both affecting hormones. Who gets hormone therapy? So it's for those at high risk for breast cancer and those with hormone receptor positive breast cancer. Hormone receptor positive breast cancer can have estrogen receptors or progesterone receptors, or even both on the cancer cell. So we are always looking for that when a patient is diagnosed with breast cancer. Why is hormone therapy important? Well, we just talked about how Hormone therapy is used to either reduce the risk of breast cancer or to reduce the risk of recurrence of breast cancer. So stopping hormone therapy earlier than your physician recommends could increase the risk of breast cancer recurrence. And of course, we do not want that. So I think as a pharmacist, it's really important to identify barriers that keep people from staying on their hormone therapy. Some barriers that I found in my practice is the lack of education. So some patients don't know what hormone therapy is or what it's for and why it's important. So we want to discuss that today. Lack of side effect management. A lot of times, no medication is without side effects. And so we want to make sure that those side effects are being managed so that our patients can stay on the therapy for the recommended duration. And then lack of communication. So sometimes it's just really hard to talk to a healthcare professional or find someone to talk to or get on the phone with someone or message someone. So we want to, decrease those barriers. And then finally, lack of resources. These can be financial resources, and pharmacists can help with copay cards or grants that might be available, but we also here at UAB at the Kirklin Clinic, we also have wonderful social workers that help with other financial resources when we've kind of hit a wall from a pharmacy standpoint. There are different types of interventions that help reduce estrogen in the body. So we'll talk about ovarian ablation, ovarian suppression, aromatase inhibitors, and then antiestrogens. Antiestrogens are broken down into two separate categories of SERMs and SERDs. SERMs are selective estrogen receptor modulators, while SERDs are selective estrogen receptor degraders. So we'll talk about each of these individually in my presentation. First, starting off with ovarian modifications, there is ovarian ablation, which is a surgery. It permanently stops the ovaries from making hormones. And this surgery is called a bilateral oophorectomy, and this is the removal of both ovaries. Another modification that can be used is ovarian suppression, and that is when we temporarily stop the ovaries from making hormones. And we usually do this by an LHRH agonist or a luteinizing hormone releasing hormone agonist. The two most common LHRH agonists that we use in practice are goserelin and leuprolide, and these are in injections that you might get monthly or even quarterly. So these two options or ovarian modifications will place patients in a postmenopausal state. And the way we define a postmenopausal state is by this criteria. Anyone who has had a prior bilateral oophorectomy, so they've had a surgery to remove both their ovaries, anyone who is 60 years of age or older, and then anyone who is less than 60 but has not had a menstrual cycle for 12 months in the absence of chemotherapy, tamoxifen, or tamoxifen. We say in the absence of those things because we know that chemotherapy, tamoxifen, or tamoxifen can affect the menstrual cycle, and so that can make it seem like you're not having a menstrual cycle, but you might not be postmenopausal. So we always have to be, checking that patients aren't on these types of therapies. And then finally, ovarian suppression and follicle stimulating hormone, or FSH, and estradiol in the postmenopausal range. This is when we are given ovarian suppression like the LHRH agonist. So patients are getting those injections monthly or quarterly, but it can take a longer time or a while for patients to really have the full effect of the medication. So we have to check the FSH and the estradiol level to make sure they're in a postmenopausal range before deeming someone as postmenopausal. Switching gears now to oral therapy with aromatase inhibitors. Aromatase inhibitors are medications that stop androgen from changing into estrogen, so it basically inhibits the production of estrogen. It does not affect estrogen made by the ovaries, so we do know that for premenopausal women, ovaries are the main source of estrogen. So aromatase inhibitors are only indicated for postmenopausal women or patients that we have put into a postmenopausal state by what we've discussed previously with those modifications. There are a few different aromatase inhibitors, but there's no true meaningful difference between the three in the breast cancer adjuvant setting or post-surgery. Listed here are the three different types of aromatase inhibitors. There's anastrozole, that's 1 milligram daily, letrozole, that's 2.5 milligrams daily, and then finally exemestane, that's 25 milligrams daily. I want to point out that exemestane does have to be taken with food, and we do usually use anastrozole or letrozole more commonly than exemestane, and that's because exemestane tends to be more expensive. Although there are potentially copay cards that can be used, in general, it can be more of a financial burden to our patients. So we usually start off with anastrozole and letrozole. For the side effects of aromatase inhibitors, a lot of these have class side effects since they work in the same way. So they have side effects of hot flashes, night sweats, vaginal dryness, musculoskeletal pain. That's probably the main thing that a lot of my patients have issues with that we try to help manage. And then bone fractures, because this can affect bone mineral density, and then cardiovascular disease, specifically in those who have a history of cardiovascular disease. There are benefits to aromatase inhibitors compared to the next therapies that we're going to talk about, but aromatase inhibitors compared to tamoxifen will decrease the odds of a blood clot or venous thrombosis and endometrial cancer in postmenopausal women. So, you know, I'm comparing aromatase inhibitors to tamoxifen, so let's talk about these antiestrogens, the SERMs, that's the class that tamoxifen is in. A SERM is a selective estrogen receptor modulator. So in the picture, it shows estrogen and anti-estrogen, which is these SERMs, and then the estrogen receptor. And SERMs block estrogen from binding to the estrogen receptor. And so then it decreases the proliferation of these cancer cells. There are three types of SERMs: taurumophene, raloxifene, and tamoxifen. Taurumophene and raloxifene we don't use too much in clinical practice, but I want to address those just for completeness sake. So we'll do that and then focus more on tamoxifen. Taurumophene is indicated for a treatment of breast cancer patients in the metastatic setting and for patients who are specifically postmenopausal. So it cannot be used in premenopausal women. The dose is 60 milligrams daily. Raloxifene is used for risk reduction of invasive breast cancer in postmenopausal females, and then also for the treatment and prevention of postmenopausal osteoporosis. Again, just note that this can only be used in postmenopausal women, and the dose is also 60 milligrams daily. And finally, we have tamoxifen, and this is indicated for breast cancer risk reduction for high-risk patients and for breast cancer treatment. The usual dose is 20 milligrams daily, and the good thing about tamoxifen is that it is available as an oral solution if patients have issues swallowing. Now, affordability might be an issue with a solution, but there are copay cards available for that for patients that have commercial insurance. There is kind of a newer or more updated dosing for patients that cannot tolerate the 20 milligrams daily for tamoxifen. Some patients can take 5 milligrams, so a lower dose of tamoxifen, but that is up to the physician and the patient's discretion. This medication, just to point out, this medication is for pre- and postmenopausal females, whereas the other 2 SERMs were just for postmenopausal females. In general, SERMs have a class side effect of hot flashes, night sweats, vaginal dryness. There is an increased risk of uterine cancer that we always, are mindful of, and then blood clots or deep vein thrombosis. So we will be watching out for that if patients are on this therapy. There are some pretty significant drug interactions with tamoxifen because it is metabolized by an enzyme in the liver called CYP2D6, and that converts tamoxifen to the active drug endoxifen. So if patients are prescribed an antidepressant, we try to avoid CYP2D6 inhibitors like paroxetine and fluoxetine, because these 2 medications are just examples of how it would prevent tamoxifen from working as well as it could. And we, as pharmacists, are always making sure that your medications are working the best they possibly can by trying to prevent drug interactions. So finally, I want to discuss anti-estrogen SERDs, selective estrogen receptor degraders. These are different from SERMs because they actually block and destroy estrogen receptors. So where the SERMs were preventing the binding of estrogen to the receptor, this actually decreases the number of estrogen receptors in the body. The medication that is currently FDA approved in this setting is fulvestrant. It's a 500 milligram intramuscular injection, and it is given 1 injection in each gluteal muscle every 2 weeks for the first 3 doses, and then monthly thereafter. We specifically use this in patients who might have progressed on an aromatase inhibitor in the metastatic setting, or patients who have an ESR1 mutation. And your physician is always looking for ESR1 mutations in this setting. A lot of times we see that for patients who have been on aromatase inhibitors for a while in the metastatic setting, they might develop an ESR1 mutation. And so that's when fulvestrant, or Faslodex is the other name, is the best option for those patients. Some side effects from fulvestrant are injection site reactions, neuropathic pain, because where the injection is given is pretty close to the sciatic nerve, so we have to be very careful not to hit that, but that can definitely cause some pain. Hot flashes and then gastrointestinal effects can be caused by fulvestrant. I want to briefly touch on a few side effect management of the side effects that we've discussed today, and then Alec will discuss further side effect management. But as far as vaginal symptoms go, a lot of patients complain of vaginal dryness. So we do recommend a non-hormonal moisturizer or lubricant. Our main go-to is Replens. That's what we usually recommend for our patients. And then if that doesn't seem to work, then a low-dose topical vaginal estrogen could be used. And our go-tos are Premarin or Estrase. And your physician might choose one over the other based on the estrogen amount in these products. And then finally, if none of those things work, then we do recommend speaking to a gynecologist who has better insight. For osteopenia and osteoporosis, which we see in aromatase inhibitors, because they can decrease bone mineral density, we'll recommend weight-bearing exercise. Your physician might recommend a calcium and vitamin D supplement, a bisphosphonate, or a denosumab. So those are options for osteopenia and osteoporosis. And then finally, for blood clots that could happen with our SERMs, like tamoxifen, we would promptly stop the tamoxifen if someone is to develop a blood clot and treat the condition of the clot, which would probably include anticoagulation with a blood thinner. So I just want to review some side effect management here, and then again, Alec will take over with the other side effect management. Before I switch it to Alec, I do want to let y'all know of some new drugs that are on the horizon. These are Alestrant, which is the first oral SERD to show benefit. So this is basically very similar mechanism to the fulvestrant, where it degrades or decreases the number of estrogen receptors. But instead of having to come up to the infusion area or the injection area to get those injections, you could, be at home and be on this oral therapy. This is based off the Emerald trial, and this is just another possible new treatment for metastatic breast cancer on the horizon. The next one is enobosarm, and that is a selective androgen receptor agonist. We haven't really discussed androgens, so just as an FYI, androgens are hormones produced in small amounts in the ovaries and the adrenal glands. This is a possible future option for patients who have androgen receptor expression of at least 40%. And this is another possible third-line option for hormone receptor positive disease in the metastatic setting. And I say third line because we usually would use a aromatase inhibitor, and then after that, fulvestrant, and then there's not really a good option after fulvestrant, so this is a good future option. I will now give or transition to Alec's presentation. And let me just give me a few moments to do that.
All righty, y'all. Good morning. Dr. Rummage did a great job of kind of giving us an overview to hormone therapy. So I'm going to try to pick up right where she left off, and then, more specifically talking about managing some of those side effects that are associated with hormone therapy. So kind of just a little brief introduction about myself. As Claire mentioned previously, I am one of our 4 first-year pharmacy residents here at UAB. And so as part of our residency curriculum, 1 day a week, I work with Claire over here in our outpatient oncology clinic in the Kirklin Clinic. And so,
hey, I'm sorry, before you continue, we cannot see your presentation. Can you share your updated presentation? Because it's still on Claire's, on Dr.
Oh, I'm sorry.
Okay.
How do we do this?
I'm just going to stop share and reshare.
Oh, good idea. Thank you for letting us know.
Yeah,
I do that a lot
Okay.
myself, so. All right, there we go.
All right, can you see that now?
Yes.
Perfect. Okay, great. Okay, so yes, so as part of my residency curriculum, 1 day a week, I'm over here with Claire in our outpatient oncology clinic. So it's been a great experience getting to, provide some of this education to patients, and then for me to be educated by patients, for them to tell me some of the side effects and things related to their treatment that I didn't previously know. So wanted to kind of give a special shout out to Claire and thank her for allowing me for the opportunity to speak with you here today. So I have nothing to disclose. So I have here listed my learning objectives, and this is, for your reference, but more so for my overview and guide as well. But really what I'll be talking about is going to be some of the common side effects associated with hormone therapy, and then treatment options, both non-pharmacological and pharmacological things that we can do to help manage some of those side effects. And then at the very end, we'll kind of introduce some natural supplements that are commonly used for side effect management, and talk a little bit more on those. So unfortunately, most medications are associated with side effects, and Claire kind of highlighted a lot of the class-wide side effects that are associated with hormone therapy. And as you can see, really across the board, there's one commonality with side effects, and it's that they all are associated with those pesky hot flashes. And so because, the hot flashes are one of the most common side effects with these medications, and also some of the most clinically bothersome for patients, I'm going to spend the majority of this presentation really talking more in depth on how to manage specifically hot flashes. And so hot flashes are also referred to at times as vasomotor symptoms. So you may see those two terms used interchangeably, but really the term vasomotor symptoms is just describing that feeling of warmth that you may experience that, spreads across the chest, face, and neck. A lot of times this can be associated with facial flushing. Other symptoms of hot flashes could be rapid heartbeat, sweating, or feelings of anxiety. And so all of these things can be very, very bothersome. And so the million-dollar question here is going to be, when do you treat these symptoms? And so there's a couple of things that we take into account when deciding, when we're going to start treatment. The first thing to consider is going to be patient preference. Patient autonomy certainly is going to be our top priority. So, patient preference is going to have a big say in it. But then, if you were to look at, the textbook definition of when to treat hot flashes, it's going to be based off of the severity and frequency of those symptoms. And so, those are really divided up into either a mild category or moderate to severe. And those mild symptoms are going to be symptoms that you are aware that you're experiencing a hot flash, but it's not very bothersome. It doesn't interfere with your quality of life. It doesn't prevent you from doing anything, normal daily activities. And I guess on the opposite hand, those moderate to severe symptoms are going to be those who are more bothersome and do affect your quality of life. And so typically pharmacotherapy is going to be recommended whenever you fall into the moderate to severe severity of symptoms. And then when deciding what agent to use for the treatment of these symptoms, we as healthcare providers want to take into account the presence of other comorbidities that a patient may have, things like hypertension or high blood pressure, depression, anxiety, urinary incontinence, and we'll kind of come back to this point here in a few slides, but I did want to just kind of give an introduction to that. And so for the treatment of hot flash, you can really separate these into your non-pharmacological interventions and your pharmacotherapy. So for the non-pharmacological things, these are going to be your first-line treatments for your mild vasomotor symptoms, but in all reality, they should be used even in combination with pharmacotherapy as well. So these are things that you can always consider. And these are things like lowering the room temperature, utilizing ceiling fans in your home or using other cooling fans, dressing in layers when you go out in public, and then avoiding triggers. And some of the triggers could be, I guess they are unique for every patient, but they can be things like eating spicy food, or my personal favorite, which is avoiding stressful situations, because we all know how realistic that is. And then I included herbal supplements here as well, or some of these natural supplements that we'll talk about more in detail later. And so on the right-hand side, we see our pharmacotherapy. And so as I mentioned previously, this is going to be preferred whenever you have those more bothersome or moderate to severe symptoms. And so pharmacotherapy is really divided into two different categories. You're going to have your hormonal therapy and your non-hormonal therapy. And I wanted to, Claire did a great job of kind of explaining the differences in the hormonal therapy, and we've kind of been using that terminology very loosely throughout our presentation. So this isn't to be confused here with the hormone therapy that you're using for either the treatment or prevention of breast cancer. So this is the hormonal therapy that I'm referring to is more specifically like oral estrogen tablets that you would take as like a hormone replacement therapy. But either way, I wanted to, draw attention to, put a big circle around, put an X through it, the hormonal therapy, because that's not what we're going to be talking about, and that's not what you will need to be taking, because hormonal therapy is contraindicated in patients who have a history of breast cancer. So we're going to scratch that. What we're going to be talking about is where you see the two stars here, our non-hormonal therapy, and then briefly about some herbal supplements as well. And so here I listed our non-hormonal pharmacotherapy options that we prescribe most commonly in practice, and we'll go through each of these pretty quickly, starting with the first of venlafaxine. So venlafaxine, its brand name is Effexor, so you will probably hear those used interchangeably, but it is a serotonin norepinephrine reuptake inhibitor, or an SNRI. And so historically, these things are used for the treatment of depression and anxiety, but it actually can be used off-label for the treatment of hot flashes too. So kind of an important point to make here is that there are very similar medications called SRIs, or the selective serotonin reuptake inhibitors, that are also used for the treatment of hot flashes. And I listed a little box up underneath to kind of show some of those. But very common medications that you are probably familiar with. And I have a point to make about these here in a couple of slides, but I wanted to kind of just introduce that here. So here are some of the common side effects that are associated with venlafaxine. And for the side effects, I tried to kind of color coordinate them according to the darker the color indicates the higher the prevalence. So nausea here would be the highest prevalence or the most common side effect of venlafaxine. And then you'll have insomnia, dry mouth, loss of appetite, and sweating. And so I mentioned previously, too, that from the healthcare provider standpoint, we want to take into account comorbidities when choosing agents for patients to use. And here's where we kind of tie that back into the presentation. So this venlafaxine would be a good treatment option for a patient who was experiencing hot flashes, but also had concomitant depression and/or anxiety, but also was not already taking something like an SSRI or SNRI at home. But probably the more important things to note here on this slide are going to be in our don't section. And so the first thing is that if you're taking this medication, you don't want to stop taking this medication cold turkey. It can precipitate some withdrawal symptoms, which are more of like, it usually presents as flu-like symptoms. So that can occur if you stop taking it without slowly decreasing the dose. But then to really drop home that point that Claire mentioned earlier with tamoxifen and the drug interactions with paroxetine and fluoxetine, those are also two medications that you definitely don't want to take if you're taking tamoxifen concomitantly. And I have our little beer can here in the bottom to help me remember to tell you guys that this is a medication that is recognized as being on the Beers criteria list. And so for those of you who aren't as familiar with that, the Beers criteria is a list of medications that's generated. And really, ideally, it's medications that shouldn't be used in patients who are 65 years and older due to the fact that they can have an increased risk of causing harm. The next agent, our pharmacotherapy agent, is going to be gabapentin or Neurontin. Gabapentin hit the market years ago as an anti-seizure drug, but really we see it used more today for its off-label uses, things like diabetic neuropathy or just in general neuropathy pain, restless leg syndrome, and then hot flashes too. So kind of one of the unique things to take away about gabapentin is that you have a lot of variety when it comes to selecting dosing for gabapentin. You can do a lower dose multiple times a day or a higher dose one time a day and, kind of get some of the same therapeutic response. And so because gabapentin can cause some drowsiness and sedation, if you are going to use a higher dose one time a day, it would be preferred to take that dose at night. Our next drug is going to be clonidine or Catapris. And so clonidine historically has been used for high blood pressure. So again, here kind of thinking about comorbidities would be a good option for a patient if they also had high blood pressure. But its FDA approvals actually has included hot flashes, but there's kind of one key caveat to that. So the 0.025 milligram tablet is what has the FDA approval for the treatment of hot flashes, and that is not available in the United States, so joke's on us there. But this option comes available as a patch. Again, keep in mind, it won't be FDA approved for this indication, but theoretically, you could kind of think of them being probably equally effective. So this could be also a good option for a patient who may have difficulty swallowing or things like that. It offers an alternative drug formulation. And our last prescription medication is going to be oxybutynin or ditropan. So oxybutynin is an anticholinergic medication that is used for the treatment of overactive bladder. And, I mentioned that it was our last prescription medication, but kind of thinking along those lines, it actually has an over-the-counter patch that is also used for overactive bladder. But it's actually over-the-counter, and offers kind of an additional formulation as well. So kind of a little unique thing about oxybutynin with that. And because of it being anticholinergic in nature, some of its side effects kind of fall into the class of the anticholinergic side effects, as we would classify. So the dry mouth, dry eyes, constipation, sedation, dizziness. And, I think probably mainly due to some of the sedation and dizziness component, it has been included on that Beers criteria list as well. Okay, so we've talked a little bit about our prescription medications that we can use for the treatment of hot flash. And so now we'll go on into some of our natural supplements. And so, first I'll start by defining natural supplements. And so the FDA refers to natural supplements as dietary supplements. But really, natural supplements is just really this umbrella term that is defining herbals, which are just plant-derived type products, vitamins, minerals, and then our non-plant-derived substances that are found to be naturally occurring. And so in 1994, the Dietary Supplement Health and Education Act was implemented and it required these dietary supplements to be safe before marketing. And the responsibility of this was going to be on the manufacturer of that supplement. So I guess kind of by Scout's honor, the manufacturer had to prove, that this medication is safe. And so one of the main ways that supplements and medications differ is that medications have to be proven both safe and effective before they can go to market. And so kind of the big thing I wanted to point out here is that just because of the DS-HEA Act of 1994 did help to kind of raise some awareness about safety associated with supplements, the FDA still does not regulate to this day these natural supplements for quality and purity before they are sold. So a lot of times you can't really guarantee the quality of medication or quality of supplement that you'll be getting. And because these supplements are not FDA approved, they can't claim to treat or cure any medical condition. And so a lot of times when you think about natural supplements, you kind of forget that these things can also be associated with drug interactions and toxicities. And so kind of the general rule of thumb as far as toxicity goes with these products, the risk of toxicity is going to be dose dependent. So essentially that just means that your risk for toxicity increases as the dose of that natural supplement increases. And some of our areas of concern, especially as pharmacists, are going to be drug interactions, but then supplements that can increase your risk for bleeding, and then supplements that can cause toxicity either on the liver or the heart. So for our drug interactions, I tried to do kind of a risk stratification thing here by putting these into categories as far as which natural supplements can cause the highest risk or have the highest risk of causing drug interactions. And the biggest two are going to be St. John's wort and grapefruit juice. And I'm sure at some point in time or another, you've all been counseled on avoiding grapefruit juice with said medication. And that's because it can increase the concentration of many medications because it prevents them from being metabolized. And then St. John's wort as well, also tons and tons of drug interactions. And so from a pharmacist standpoint, I'm always going to recommend to try to avoid St. John's wort if at all possible. And moving right along to the products that can increase your risk for bleeding, you definitely want to think of the 5 Gs: garlic, ginger, ginkgo, ginseng, and glucosamine. So if you get bored, try saying that fast 5 times in a row. So a lot of these things can occur just naturally by the way these natural supplements work, but also through drug interactions as well. But wanted to kind of just highlight these here for you and provide these for your reference. And then as far as the toxicities goes, this is more so just included here for completion's sake. One of the ones that we'll be talking about more specifically will be black cohosh, which can be used for the management of hot flashes, but it can be associated with liver toxicity. And so I'm going to run through a couple of the side effects that are associated with hormone therapy, and then some of the natural supplements that are used to treat those side effects. And so here we see our hot flashes, and these are things that have been studied and have been shown to be possibly effective for the management of hot flashes. And we have our black cohosh, soy and red clover, and equal. All of these 3 things are going to be phytoestrogens, which are essentially just hormones produced by plants that are pretty structurally similar to estrogen, And so they can interact with some estrogen receptors in the body, and which can be, kind of lead to some clinical controversy surrounding whether or not they should be used in patients with breast cancer, with a history of breast cancer. But from everything that I've seen, and again, keep in mind that there's no concrete guidelines to kind of guide this decision, but it seems to be that these are still safe in patients who have a history of breast cancer. And so while these things have been studied, our magnesium, wild yam, vitamin E, they have been shown to not really be effective. So the biggest thing to point out here is, again, going to be with our safety concerns. And so I mentioned previously that black cohosh can be associated with that liver toxicity. And then St. John's wort has actually been shown to be possibly effective for the treatment of hot flashes, but I didn't even want to include it because it has all of the drug interactions, and it is a pharmacist's nightmare. So I just did include it here for completion's sake and wanted to re-highlight the drug interaction component with the St. John's wort. And so the next side effect we could talk about is pain, which I tried to break up into separate categories based on really the mechanism of the pain. So you have your joint pain, your arthralgias, your neuropathic pain, and then your muscle pain or myalgias. So if you're experiencing arthralgias, you have a lot more options that have shown to be possibly effective. Most of the time, this glucosamine will be used in combination with conjointin. These two come as a combination product that are sold over the counter at most pharmacies in the country. But then SAMe is also shown to be likely effective, along with capsicum, which is the component that's in a lot of topical creams known as capsaicin, but it's actually derived from a chili pepper, so it kind of helps provide some local pain relief. Oh, and then turmeric. And so the other options here, neuropathic pain and myalgia, don't have a lot of evidence to really support the use of some of these things, but I did want to include them there just because they are often used. So the next symptom would be, we'll talk about, is nausea. And so acupuncture, which is really more of a non-pharmacological intervention, and peppermint, those two specifically have been shown to be effective for chemotherapy-induced nausea and vomiting. So might be essentially a good option to consider if you're experiencing nausea related to chemotherapy. But then ginger has also been used as well. And alopecia, kind of along the lines of myalgia pain and then neuropathic pain, don't have a whole lot to support its use of natural supplements. So some things that have been used are zinc, and then you would think that biotin, being the hair, skin, and nails vitamin, would work pretty well, but it doesn't have a whole lot of evidence to really support its use. But I did want to include this here just for you to see. And so kind of the big takeaway points here that to keep in mind that natural supplements are not FDA approved, and they're not FDA regulated, and just because they are a natural supplement doesn't mean that they aren't associated with adverse effects, toxicities, and drug interactions. And then because of that, it's always important to discuss the risk versus benefit of taking these things with your healthcare provider and then your pharmacist as well. Okay, so that will conclude my portion of the presentation, and this time we'll open up the floor to questions.